Good evening. Thank you for joining me tonight for this podcast talking about beyond basic non-invasive tests. My name is Brian Lamb. I'm a physician assistant out here in Northern Virginia, just outside Washington, D.C. Serve as the Associate Director for Research at Inova's Liver and Obesity Research Program. We're going to talk about three things tonight. We are going to talk about when do you need something more than your basic NITs. So when should you do something besides FIB4 and transient elastography? We'll then go on and talk about MRE elastography and PDFF. And then finally, we'll talk about when you would want to consider liver biopsy. So let's jump on into the first question. When is it appropriate to consider something besides FIB4 and transient elastography? And that's a common question we receive. Firstly, it's important to say that none of the guidelines recommend making the diagnosis of MASH using the FIB4 alone. Now, unless the FIB4 is very high, above 2.67, then you can assume that the patient has advanced fibrosis. But even with a high FIB4, I always like to get a second NIT, like elastography. FIB4 is really meant for primary care docs and the initial screening because FIB4 is widely available. It's just, as you know, based on age, platelets, AST, and ALT. And so that's really meant for just general screening in endocrinology and primary care offices. The other consideration that we want to make is that for most patients with at-risk MASH, that's MASH with stage 2 or stage 3 fibrosis, elastography is sufficient to make the diagnosis. So for 80 to 90% of my patients with MASH, all I need is a good fiber scan, and then I can tell them, you've got MASH. So then the question is, when is transient elastography or fiber scan, when is that not sufficient? So I can basically think about two situations where you would want to get something besides just a fiber scan. First situation is when you have a suboptimal TE exam. And the second situation is when you've got a good exam, but the numbers don't match up and you have some discordant NITs. So let's talk about the first situation when you have a technically challenging TE. As you know, elastography can be difficult when the BMI is above 30 or 35, or also just depending on the patient's body habitus. You got to get them to crane on over onto the right side. And so sometimes the rib spaces are very narrow, or if the patient has a very short trunk, or if there's a lot of adiposity, or if the patient has had bariatric surgery and have a lot of loose skin over their ribs, that can make it difficult to get good TE images. I do think that if you are planning to treat MASH and you're an APP in the GI and liver space, you should get comfortable looking at the data captures or the images. If you're ordering the fiber scan or the TE from a radiologist, don't be content with just a report that gives you a KPA number and says 10 KPA consistent with stage 2 to stage 3 fibrosis. You really need to tell your radiologist or whoever's doing the fiber scan for you, send me the report that has the 10 images of the data captures, and get used to looking at those lines. Make sure that's a nice, sharp black line with parallel margins. You don't want to get any cones that are all spread out. You don't want a lot of, blurriness there. You really want to be able to distinguish between a reliable fiber scan or reliable TE exam and one that is not very good. So I think it's important to start educating yourself on how to do that. So that's the first situation where TE is not enough. If you have a bad, unreliable fiber scan exam. The second situation is when you've got a good TE exam, where there's nice sharp lines, at least good 10 measurements. There's not readings all over the place. You don't have like 5 kilopascals and 12 kilopascals and 40 kilopascals. They're all within a reasonable region, meaning that the IQR over median is below 30% or below 25%. So you've got a good TE exam, but it doesn't fit your hunches. It doesn't fit your clinical suspicion or doesn't match up with the rest of your data. So one example of when it doesn't fit the picture is, say I have a patient who had a good TE, a good fiber scan with 15 kilopascals, and he went and did the work. Over 6 months, he dropped 20 pounds. He stopped eating junk food, stopped drinking, started exercising regularly, and he's lost a lot of weight. And I would expect that the liver stiffness would improve. And he comes back 6 months later or 9 months later, and the liver stiffness is worse. That's a situation where you're like, I'm not sure what's going on here. let's get another test. And the other common example is when you have discordant NITs. If the patient has an ELF that's really high and then the FibroScan is really low, then you may need to look into other non-invasive tests. So in summary, like the guidelines recommend, if the FIB4 is over 1.3, refer to me, or refer to your friendly GI Hep APP for further evaluation. That's what I tell primary care and endocrinologists. If above 1.3, send to me. Again, if the patient is 65 and over the cutoff is 2.0, and once you know that the FIB4 is abnormal, then get a TE, FibroScan exam, and number one, learn to recognize the difference between an adequate TE exam and a suboptimal one. And then two, if it's an adequate TE, but it doesn't fit your other data, then you'll want to order another test. Well, what other tests are there? I'm glad you asked. Okay, so now we're going to talk about MRE. So that's the MRI version of elastography. And again, not all radiologists are going to have this. This is going to really depend on whether your MRI facility does elastography. So you want to call them and ask. But essentially, it's just like the FibroScan, except it's the patient's going into the MRI and they place this large caustic paddle on the ribs there. It bounces a bunch of waves there through the liver, and you get a larger area. Just like with FibroScan and TE, accuracy depends on operator experience. So just make sure that the person who's doing the MRE has done a good amount, at least 15, 20 MRIs. The first couple MRIs, if it's their first go around, you just want to read those results with a grain of salt. But all said, MRI is your most accurate imaging NIT. For details about accuracy, you can look at the article in Hepatology in 2021 by Dr. Rohit Lumba. They looked at about 550 patients, and when looking at the ability of MRE to rule in MASH with stage 2 or stage 3 fibrosis, the positive predictive value of MRE was about 90% compared to just 72% for VCTE. So MRE is quite a bit more accurate if you can get it. The other thing to consider is you want to remember that kilopascals does not equal kilopascals all the time. So the range for liver stiffness is different for TE than for MRE. So as you know, for transient elastography for FibroScan, stiffness in the high kilopascals, 18, 19, 20 and above, that's consistent with cirrhosis. On the other hand, for MRE, liver stiffness above 5 kilopascals is consistent with cirrhosis. So just make sure, depending on the report, just look at the range that they send to you or refer to the guidance that's out there on the MASLD community network. Also, it's important, if you're getting an MR elastography, also ask for the fat fraction. Oftentimes that's called proton density fat fraction, PDFF. That's the one that was most commonly used in most of the MASH clinical trials. However, depending on your MRI center, depending on their software, it might be called something else. But just ask for fat fraction, because when you get, whether you're getting a TE or MR version, you want to get some measure of liver stiffness and some measure of fat. In the Maestro-NASH trial with resmetirom, the strongest predictor of histologic improvement was a 30% drop in the fat fraction. So, once you're treating patients with medications for a year, you want to see an improvement in both liver stiffness, ideally both liver stiffness and fat fraction, or one or the other. So that's a good test. If it's available in your area, that's my go-to test if I'm not sure what's going on with my liver stiffness by TE. Other things that's worth saying, when you're treating patients with liver-directed therapy, stiffness and fat fraction by CAP on FibroScan will also improve. You can look at the ASLD practice guidelines by Vincent Chen that were released in 2024 for some of those data. Some final thoughts on MRE. If you're ordering an MRI for another reason, like you're trying to assess and evaluate a liver lesion, ask them just to throw in elastography and fat fraction as well. That's typically when when do I order MRE? Whenever I can, or when I'm ordering an MRIs anyways, or if the transient elastography is unclear. Finally, maybe let's spend a couple minutes talking about liver biopsy. Basically, there's only two situations when I order liver biopsies now. For most of my patients, when I'm evaluating for MASH, the non-invasive tests with an ELF or FibroScan will help me make the diagnosis in like 80 to 90% of my cases. The two times that I'll order a liver biopsy is if I'm suspicious of something else. Like if I'm thinking, oh, I'm not sure if there's autoimmune hepatitis. This patient has an ALT of 250 and the smooth muscle antibody is positive. Then I'll do a liver biopsy to make sure that there's nothing else going on. Or if I'm assessing for cirrhosis. Now, as you all know, currently in June of 2025, resmetirom or Rezdiffra is not FDA approved for patients with MASH and cirrhosis. It's only approved if there's at-risk MASH, consistent with stage 2 or stage 3. So if I want to, if I have a patient come back with kilopascals of, a TE with liver stiffness of 18 kilopascals, maybe their platelets are a tad bit low, 140, 130, and I'm not sure if they have cirrhosis, I'll get a liver biopsy just so I know what I'm dealing with. This may change if resmetirom gets approved for patients with cirrhosis in a couple of years. They have that ongoing cirrhosis trial, which should read out in 2027, 2028. Also, at EASL in May of 2025, they did release data on those 122 patients with compensated cirrhosis who are on resmetirom for 1 or 2 years. Safety and efficacy data looked pretty good, so we may get a little bit of opportunity to start treating patients with compensated cirrhosis. But for now, the hard FDA indication is just stage 2 and stage 3 fibrosis. So you could get a liver biopsy if you want to make sure that the patient has stage 3 and not stage 4 or compensated cirrhosis. So thanks for joining me tonight to talk about NITs. Thank you for your time, and we'll see you on the other podcast. Take care.